Hello, everyone, and welcome to the COVID Data for Your Research, a dataset tour of the COVID-19 Data Project. So I appreciate everyone joining us today. My name is Tracy Flood, and joining me are our panelists, Sarwat, Kaiynat, Allison Muir, Aisha Saleem, Evangelia, and Jeff. So we've got a lot of people joining in the conversation today. Let's talk a little bit about the outline of what we hope to go over. So during this webinar, we are going to be learning a little bit about Broad Street, learning a little bit about the COVID-19 Data Project initiative, and then we'll hear a little bit more from each of our four panelists talking about data sets. Each and every one of them has been part of data collection efforts. And after we hear about the four data sets from the four panelists who will be presenting them, Evangelia will be showing us where we can find the data. And then Jeff will be leading us in a Q&A session at the very end. All right, so let's start by hearing a little bit about the Broad Street Institute. So the Broad Street Institute is a Wisconsin-based nonprofit corporation in the process of applying for 501c3 status. We were established during the pandemic as a place for scientifically minded people from around the world to come together and assemble good data. Altogether, we've had over 1,400 volunteers from public health, data science, healthcare, biology, and other fields. Even though we may be different in many ways, we come together for different data projects, and we have a shared belief that good data can heal the world. The Institute has three major goals. The first goal and our main priority is to support our interns with training and skill building to ensure that the volunteers of today become the leaders of tomorrow. The second goal is to assemble and share good data to inform research and community change. And finally, our third goal is continuous improvement. We really want to build an adaptable infrastructure that gets better month to month. And so we implement an agile and lean methodology. All right. To date, I'm happy to say that we've had hundreds of researchers engage with our data. Our maps with downloadable data have been embedded and shared 45,000 times, and we've inspired policy recommendations, grants, and journal articles as well as some poster presentations at conferences. Now, you might be thinking, this is all really nice, but why is a workforce of 1,400 people needed to collect data on the pandemic? Nearly 2 years ago when the pandemic first hit North America, the public data infrastructure in the United States really wasn't quite ready. And what we found was that each state had a unique and different reporting system. We found that in order to have the highest quality data, we frankly needed to collect it and quality assure it ourselves. And now as more data infrastructure is being built in the United States at the federal level, we'll be strategically adjusting our activities as well. So let's talk about what the COVID-19 Data Project is doing currently. So currently, the COVID-19 Data Project as an initiative of Broad Street has multiple data collection tracks. The first is our daily numbers track. It collects and quality assures COVID-19 cases and deaths. Next is our vaccine track, which collects data on vaccine distribution, including third doses. The policy track has collected 1 year of data. The policy track has collected and coded 6,000 plus policies at the city, state, and federal level. And the health equity track has collected data for 1 year on cases by race and ethnicity at the county level. This track was sunsetted this past summer as data on race and ethnicity became harder and harder to find. So each of these tracks publishes data to the public monthly, and we'll be hearing at the end how to access that data. As far as the different time ranges go, you can see the timeline of data availability here. You can see that the vaccine data is more recently added, the health equity data covers 1 year, and policy and daily numbers data spans nearly 2 years now. I'd now like to hand it over to each of our track managers to tell you a little bit more about each track and our data. I'll start with Sarwat of the daily numbers track.
Thank you, Tracy. Hi, everyone. Thank you for coming, and I'm excited to have you all here to talk about our data set. My name is Sarwat, and I'm responsible for overseeing the daily numbers data track. In the daily numbers data set, we report cumulative data on COVID-19 cases and deaths of every single county from every single state in the United States, including Washington, D.C. and Puerto Rico. The track and its volunteers started out in March 2020, but our data stretches back all the way to January 2020 when the pandemic initially hit the United States and the first few cases and deaths were reported. We originally started with just one spreadsheet of data covering all 50 states, and we only had about 20 team members, but now we have over 150 active team members at all times on 6 regional teams, and we have well over 60 spreadsheets just overflowing with data on cases and deaths. Data has always been collected 7 days a week by our data entry team members for the following 4 variables: confirmed cases, probable cases, confirmed deaths, and probable deaths. This is followed by work from our quality assurance team members as they do a quality check of our data by checking our data with specific historical sources to verify the entry is correct and to fix trend breaks. And we also compare our data with that of Johns Hopkins University, New York Times, and USA Facts using automated comparison set checkers. Doing QA like this makes our data set very unique in that our data is updated and corrected by quality assurance reviews in the days, weeks, and months following initial entry. I'd just like to take a moment to emphasize the sheer volume of team members working around the clock on the project to keep the data up to date and clean, and the numbers that have contributed to it historically, and just how truly amazing that is and how none of this would have been achieved without their contributions. This here is what our data set looks like. States are broken down by county, and each state includes data for cases, probable cases, deaths, and probable deaths. Data entry team members enter in daily numbers while quality assurance team members adjust if needed, and they leave comments on cells indicating they have done so. This is not exactly how the published data on our GitHub looks like, but this is the information that gets directly transferred over onto our GitHub. And columns such as that for the FIPS code, which are on our GitHub file, are hidden on the sheet. Our methods are recorded on a Google Sheet, providing information on definitions and processes of all states that data is collected for. This sheet is updated with every release, and it's included in our release notes. Below is a limited snapshot of what this method sheets includes, but the full list of variables on the sheet are listed here on the slide, as we do not have a big enough screenshot to capture all the variables on the sheet. Methods and definitions of cases and deaths do vary by state, as you can imagine, as every state has a different public health data reporting infrastructure, and even individual counties at times have different updating data reporting structures in their states. And so we truly try our best to make sure that this is reflected and updated with every release. That being said, we work with a lot of states and we work with a lot of data. And so we do face quite a number of challenges on the daily numbers data set. One of the biggest challenges that we face is that each state, and like I mentioned, counties at times, report data in different formats. You'll notice on the right side of the slide here that this is a snapshot of the Arizona COVID-19 data dashboard, and below is a dashboard of the Connecticut COVID-19 data dashboard. In some cases, we can copy and paste over totals depending on the format, like we can for Connecticut. However, for other cases like Arizona, we often have to click on every single county to get the cases and deaths. And specifically for Arizona, to get probable numbers, you have to hover over the cases numbers. So the way that states report data varies a lot, and such differences in data reporting formats can cause large variances in the time required to complete data entry. Another big challenge that we face is that a large quantity of data often causes QA processes to lag. Like I said, multiple reliable sources may report conflicting case totals in many counties, and if the state is being notified by cases of the individual county health departments of these updates a little bit later, they will only be able to update these as they are reported. And so our numbers that we initially report may not be as updated. And so to help with this, we have set up QA comparison set sheets, which will notify of a discrepancy in our recorded data. And a screenshot of one of our comparison set sheets is included here on the left. The last major update that our data set faces is that historical updates of our data by the state or county source. This means that some of our states and counties provide the historical set of their data. And so while this is helpful for QA processes, some states use this historical data dashboard to update their data for old dates. Kansas is a very good example of this in that it's constantly updating its historical data. And so to attend to this, we have organized monthly data bursts very close to our data release date to make sure that we are providing the most accurate data by date of event. This makes our data set very special as we are the only COVID-19 data aggregator by date of event in the entire country. Some frequently asked questions that we get. So how is updated historical data reflected in Broad Street data? We do provide the most updated data by date of event. So whatever the most updated number on the source was at the end of the day is what we have included. And our data bursts reflect that for historically updated data. Where can I find your defined methods? This is available through a website on our webpage and also available on our GitHub, which we'll show you how to get to towards the end of this webinar. And the other major FAQ that we get is what are differences and similarities with how states have been reporting or recording data. So most states publish their data set through their state health department sites, but some states do publish their data sets through individual county sources. The format for each publication varies, but it usually falls into the following. So we've seen CSV files, Excel files, Tableau dashboards, PDF reports. And like I said, we also do utilize some county sources, and counties often report through more frequently, so they utilize social media pages such as Facebook pages where they post their press releases. With that being said, I would now like to pass it off to Kaiynat, who will be reporting on the vaccine data set.
Thanks, Sarah. Hi, everyone. My name is Kaiynat, and I'm responsible for overseeing the vaccine data track. In this data set, we report daily cumulative data on COVID-19 vaccinations of every single county from every single state in the United States, including Washington, D.C. and Puerto Rico. This track began in March of 2021, originally with a team of just 12 interns, and we were solely archiving data for states that completely overwrote their data within a 24-hour period. Now we have 9 teams and have had over 140 interns on the track and are reporting data on all 50 states plus DC and Puerto Rico. Similar to the daily numbers track, data is collected 7 days a week on this set and has been since April of 2021. When the track first started, we were collecting data on 4 variables, but with the addition of booster doses being administered in recent months, we are now starting to report data on 5 variables: first dose, second dose, single dose, or Johnson & Johnson vaccines, additional doses, and total doses. Each state differs in how they define these variables, and we have done our best to unify the reporting within our data set. Data is recorded at the county level from all 50 states, DC and Puerto Rico. Most of our data is obtained through state dashboards, but in some instances, individual county level resources are also utilized to make our data set more holistic and complete and accurate. We do have a QA process within our track to review those data sources and ensure accuracy and high quality of our data set as well. This data set allows individuals to visualize vaccination status across counties, states, and the United States through a longitudinal data set. Next, you'll see a data snapshot of what our data set looks like. States are broken down by county, and each state includes data for all 5 variables that were previously mentioned. You'll see at the top of our spreadsheet, we have 2 rows, one where the state name is listed and one listed as state totals. The row with the state name is auto-calculated based on the county entries for each variable, and the state totals row is the number reported by the state as the number of vaccinations administered for each variable on their dashboard. Ideally, both rows should display the same number and helps in our QA process of identifying any discrepancies in reporting. However, there are numerous instances where those numbers do not match up. One instance where that occurs is when the county level data is not updated as often as the state level data. Some states don't report their data 7 days a week. They might report it weekly or on Monday, Wednesdays, and Fridays. And when county level data is not updated daily, the most recent update is inputted until the next data refresh is provided. The other most common instance where that occurs is when something is reported at the state level, but it's not reflected within county level data, such as federal entity vaccinations. Before beginning the reporting of vaccination data, we had to do an assessment of what data existed and what existed at the county level. Through that assessment, that led to the 4 variables that we have been reporting since the start of the track of first dose, second dose, single dose, and total doses. And prior to beginning the data collection for each of the states, each dashboard was reviewed for definitions for those variables, and those definitions were recorded and are reported each month when we release our data set. As we began data collection, there were varying stages at which data collection began for each state. Below is a snapshot of a table also released with our release each month, indicating when data collection began for each state and whether historical data exists for the state that can be released at a later time. Methods and definitions vary by state, so we try our best to capture and reflect those differences each month with our data release as well. Some common challenges with the vaccine data set. One of our main challenges that we faced was the defining of variables among states. Each state had their own unique definition of the variables and displayed that data differently. Like I previously said, prior to beginning data collection, we did go through each dashboard and noted how they defined their variables and attempted to unify those variables based on those definitions. Here you see a snapshot of the variable definitions by state. These definitions are reviewed on a monthly cycle and are updated before each data release. Another common challenge that we face, similar to the daily numbers track, is that vaccine reporting is also reported in different formats. On the right-hand side, you see Georgia's dashboard, where you would have to click on a drop-down to select a county and then report the data that way. And then on the right-hand side, you see another state which has a PDF file, so the data entry can more easily be inputted. The third challenge that is commonly faced with the vaccine data set is at the start of the track, we had various geographic reporting for the vaccine data. Most states did report data at the county level, but a few reported it via different geographic breakdowns. You can see on the right-hand side that Oklahoma provided vaccinations by zip code. And on the left-hand side, Utah provided vaccination data as a mix of jurisdictions and counties. This varying geographic breakdown made it difficult to report the data easily at the county level. Investigations were further made to determine whether any data could be obtained at the county level directly. Unfortunately, we were able to find secondary resources that had county level vaccination data for these states and were able to adapt our reporting and methodology to incorporate that information. Some common questions for the vaccine track is, do other resources report this data? At the time that this track started, tracking of vaccination data at the county level was not centralized. Only state level data was available. However, as time has gone on, cohesive data sets are starting to become more present. How do you ensure your data is accurate? We have implemented QA processes within the track to ensure that that data is both correctly inputted and of high quality. We also continuously monitor changes in reporting and update our methodologies to reflect those changes to ensure our data is accurately reflecting the data reported on state and county websites. And then the last question we commonly get is, what differences and similarities have been noticed in the state's reporting and recording of data? Most states publish their data sets through state health department sites. The format, like I mentioned previously, does vary, and similar to the daily number set, the common formats that we see are CSV files, Tableau dashboards, or PDF reports. The most difference that we see with state reporting is in how they define a specific variable and which variables they report. For example, single doses was not available or is not reported by every state differently from their other variables. Some states report it within their vaccine initiation number, others in their fully immunized number. And this gets captured in our variable definitions table within our GitHub. This is the same thing that we see with additional doses as well. Not all states report that data, at least not yet, but we are tracking it as it becomes available and updating our methodologies to reflect that. Now I would like to pass it off to Allison, who will report on the policy data set.
Thanks, Kaiynat. My name is Allison Muir, and I currently oversee the policy track. Here in this slide, you will see a breakdown of anything and everything about the policy track and a very quick snapshot. You will see our variables later on. The policy track is different from everything else you're hearing about today because it is qualitative data. Rather than numbers and case counts and finite detailed quantities, we're looking at whether things are included or not included. So a lot of yes, no questions based on policy orders. We have been collecting orders and official documents since April of 2020. Our data now covers all 50 states, 6 US territories, around 188 cities and counties, and also any federal level orders related to COVID-19. What all that means is that within our most recent release from the 1st of October, we captured 6,268 official documents. Those documents range depending on what level of government they come from, but they are all official enforceable documents. Since we began in April 2020, we have had around 168 active members. Those numbers increase and decrease based around when our members and interns are most active and most available. And our track size has resulted in 3 teams. So our teams and our active members break up and divvy up the work to collect our data. Our qualitative data is gathered in relation to specific scope topics, and each document is reviewed for those scope topics that are gathered from the local government sources. So not only do we seek out these official documents ourselves from the government resources, their websites, anything that we are able to find online, we also review each one individually. These scope topics that the documents are reviewed for were developed in collaboration with Temple University's Center for Public Health Law Research. That organization really worked with us and shared their knowledge and understanding of what was important for COVID orders. And we applied a crowdsourced method to capture it quickly and keep up with the demand and the large flow of documents being released. Our quality assurance process involves completing checks to make sure that all information has been gathered for each document. We make sure that our information actually pertains to COVID-19 and is relevant to what our data set is about. And we also want to make sure that our scope criteria still remains relevant more than a year on. All of our work and data set is published in multiple formats. Most applicable is the Github content that you will see later today. The Github does not have all of the same citation that some of the other methods that are published do, but all of the same information is captured and represented so that nothing is lost. Here on this slide, you will see all of the variables and why they were not listed in the previous slide's chart. The order identifiers on the left of your screen are identification topics. They are things that represent that particular document, that particular order, and they define what that order is. On the right side of your screen, you'll see all of the scope criteria that we review for. Whether or not any of these topics are included in the order in the document, the official document. If any of these are included, we represent that yes or no question, and we capture to what extent they are included. We also capture miscellaneous notes or important details about each document in a miscellaneous notes column. When I say we capture everything to answer a yes or no question, this slide gives you a visualization of what you would see on our data set. Our order identifiers are a little bit different in that the state, it is either a state or a city or a county. That's obviously a word. The location is the location where the official document is from. The order number, order name matches whatever that location or governing body decided to name the document. But the majority of our data set is ones and zeros. This binary variable allows us to quickly say yes or no whether or not a scope criteria topic is included, and it makes it very visually easy to capture and run reports to find out what documents actually pertain to any content or topic that you are interested in reviewing. What you see here is a visualization of what you would find if you were to look for the second half of our data set. So in addition to the ones and zeros on the massive spreadsheet indicating what's included, we also give you machine readable versions of each official document that we review. We have all of those, all 6,268 in a machine readable version. Those versions could be official documents that are emergency declarations, public health orders, statutes, regulatory documents, even mitigation policies. Here you'll see how our folders are broken down, just very simply. We separate them based on what type of geographical location it is, and then further by what specific location it is. The territories is the quickest and easiest visualization of that, but I'm sure you can apply it to any of the other locations and understand how it would be able to be navigated. What you see here is a breakdown of what our actual spreadsheet looks like. Our data is collected by those teams, by our members broken into teams, and they work together to support each other. During team meetings, what we call data bursts, our interns and our active members work together to tackle each step of our process. Our process has conversion steps, it has entering the data and reviewing each individual document, and then it has, again, more conversion steps to make sure things are correct, and then QA process. All of that is captured within a single spreadsheet within different tabs across the bottom that you briefly see in this picture. And it allows our interns to all work together on a familiar format like Google Sheets and Zoom, which they've all become very familiar with during this pandemic, so that everyone is able to support each other and answer any questions that come up right then and there, rather than having to wait and delay the process for question and answer. Some challenges within the policy data set, similar to what some of the other tracks and of some of my co-presenters here have mentioned, that every state is different. In the pictures you see immediately, you'll notice that the state of Indiana likes to use very pretty paper on their digital PDFs. They have this beautiful border that they have included on every single version of their official documents. However, PDFs are not machine readable, and when we work to convert that document, we lose much of the information. Their border is lost, the fancy font is distorted, and the format goes out the window. We have navigated this and come up with further QA processes to ensure that information is not lost, but it is definitely one of our biggest challenges. That also plays into how accessible the documents are online. Each state, in each city, the territories, even the federal government, everyone publishes their official documents differently. Whether it's a downloadable PDF, it could be a HTML that's embedded directly into their website. It could be a PDF that you have attached to a Google Drive that has public access. Every single location does it slightly differently, and we do have to navigate those differences and understand what we're looking for in order to capture the correct information. We have additional format issues that come up, including if images are on the PDF, if there's any signatures, but again, all of that is corrected and accounted for during our QA process. Here you see some frequently asked questions of the policy track. Have you seen any differences based on political representation? For this question, it is important to recognize that the pandemic has spanned across the election and across many mayoral changes and governing changes for each state. There have been differences to reflect the political party that each governing person holds. However, overall, as time goes on, many states are becoming very standardized. There are outliers, which I'm sure everyone is very familiar with within the news, but in general, every state is very similar in how they are legally trying to control the pandemic through orders. In terms of geographical differences, there are more differences than politically based. Geographically, in terms of the states in the Central West that have less dense population, have very different orders compared to those of very large metropolitan cities that may be along the coasts of the country. This goes hand in hand with the case number that you see and just the population density that you see, and the orders reflect what best fits that particular location. How does this data set correlate with the other data sets? All of our data sets are not only on GitHub, they are also all connected by the FIPS codes that you have seen throughout this presentation. Those FIPS codes align so that you can connect all of the data sets together and look at one singular location and how the cases and deaths have come about, how their vaccine has been rolled out, and what policies have come about in that location. What was the effect of holidays? Just like the election that has come and gone, the holidays bring about differences in reporting because those uploading to the websites are on vacation. There have been spikes in cases over the holidays, but our favorite thing that has come from the holidays is a sense of joy and laughter. We have seen orders saying that Santa Claus and the Easter Bunny are exempt from stay-at-home orders. We have seen social distancing rules been relaxed for these fictitious holiday characters, and it brings a sense of levity to a very serious situation. The vaccine itself has had orders itself related to it in terms of who is able to get the vaccine, where to get the vaccine, and how frequently to get the vaccine. The number of orders has not declined, but the vaccine themselves has started popping up more and more in the orders that we still see being published. Now I'd like to pass it off to Aisha, who will report on the health equity data set.
Hi, thank you, Allison. Hi, everyone. Thank you so much for coming. My name is Aisha, and I was responsible for overseeing the health equity track before it was sunsetted. Our health equity data set collected data on cumulative COVID-19 cases by race ethnicity at the county level. The variables we collected were confirmed cases for all races and ethnicities according to US Census guidelines. As you see in this table over here, the races and ethnicities are presented. We started collecting this data in June 2020 and updated daily or as frequently as the websites themselves updated this data. On June 2021, we decided to sunset this track because we noticed that states stopped reporting it. Although we are no longer reporting this data, we have a year's worth of race and ethnicity data on the county level. And we had a total of 332 interns in the past year who contributed to this data set. But originally, when we started in June, there were about 750 counties that were reporting race ethnicity data. Since then, however, the amount of counties has grown and we worked with at most 1,500 county websites. Looking at it more broadly, there are just over 3,000 counties in the US, which means that about half of all counties in the US reported race ethnicity data on the county level. One reason why our health equity data set is useful and important is because it is the only data set of its kind in existence that we know of. Although other sources do report COVID cases by race and ethnicity, they do this at the state level. We are the only ones collecting this information at the county level, giving our data set a level of depth and specificity that you won't see elsewhere. Additionally, in most states and counties that we work with, the case data gets overwritten daily, and they don't include any kind of historical data, which is why it's so important that we capture this data in real time and why it's been such a massive undertaking. Because of this, our data set is uniquely situated to help analyze longitudinal trends and identify health disparities across demographics. In addition to this presentation, you can find more information on this data set on our GitHub folder titled Race Ethnicity Data. As I mentioned in the previous slide, not all counties report race ethnicity data, and the number of counties that do has doubled just in the time that we started collecting this data. We established a county update process where we have a master list of every county in the US, and once a month we would go back to see that list and check every state and county website for those counties that don't yet report race ethnicity data. When we first started out on the track, we would usually find 1 or 2 new states, but over the last months of the track, we started to see that taper off. We began noticing infrequent reporting in March 2021, with states such as Tennessee and Oklahoma that switched from reporting daily to once a week and eventually stopped. Because of the large number of states that began to report infrequently or stopped reporting completely, we decided to sunset the track and stop doing data entry in June 2021. Here we've got a snapshot of our data entry spreadsheet look like. It gets cleaned up a bit and converted into long form for publication, so this isn't necessarily how you would see it displayed when you download our data set, but we do have a wide form converter if you prefer to use the data that way. Essentially, we have the county names here on the left, and the column is hidden on the spreadsheet, but we also have FIPS codes for each county that appear in the final published version. And we have the various races, ethnicities that I mentioned before on the top and the confirmed cases for each one. In the next two slides, I wanted to address a couple of challenges that we face by collecting this data. So the biggest challenge by far that other track managers have also mentioned is that pretty much every state reports race ethnicity data differently. We've included two screenshots of different state websites to highlight that here. So on the left over here, you see Ohio, which includes case counts and numbers, which is pretty much the best case scenario, but you have to search for each race individually, which is a bit time consuming. On the other hand, we have Indiana on the right, where data is reported in percentages that need to be converted to numbers using the total number of cases for that day. This is a process we've been able to automate and embed formulas into our spreadsheet to calculate for us, but it definitely posed a challenge for us in the beginning. On the second slide, you see the Virginia Department of Health website. Virginia is an example of another challenge that we faced, and that is the challenge of health districts. We collect data on the county level, but in some states like Virginia, data is reported on the health district level, which is basically a grouping of several counties, usually done to preserve anonymity in particularly small counties. This posed a challenge for us because there was all this great data being reported at the level super close to the county level, but not quite there, and so we had to adapt. What we ended up doing was using Virginia demographic data to proportionally break down cases from the health district to county, depending on the demographic of each county in the group. Places where we did this are specified in our release notes in our GitHub for greater transparency. And now I'm going to answer some common questions that we've had about the track in the past year. So the first question is, do other resources like the New York Times report this data? And the answer is that they report this data on the state level. We are the only ones by far that I know of that report this data on the county level. A second question is, how did you ensure that your data is accurate? And when we are actively reporting this data, we implemented a QA process, quality assurance process, to ensure that the data was entered correctly each day. And another question is, do states report historical race ethnicity data? And most states did not report historical data. It was overwritten daily for most states, which is why it was so important it was captured each day. And now I'll pass it up to Evangelia for the GitHub tour.
Hello, everyone. My name is Evangelia, and I work assisting Sarwa in managing the daily numbers track. Now that you've heard a bit about each of our data sets, I would like to discuss how to access them using GitHub. For those of you who are unfamiliar, GitHub is essentially a code hosting platform used for version control and collaboration. In order to access our GitHub, you can directly click on this repository link, which will be provided. The first thing that you see will be that there are 6 repositories. A repository is essentially a folder, and the 4 different data sets that we talked about, cases and mortalities, vaccine data, state and city policies, and the race and ethnicity data will be found here. In order to access our CSV files, you can directly click on the link of each of these data sets. Once you click the link to the data set, the first thing you will see will be a description of the data and any key variables in structure, methodology, which is updated monthly, and the citation we suggest to use at the bottom of the page should you decide to use our data for your own analyses. In order to access the CSV to download, all you need to do is click the code button at the top of the page. Then you would click Download Zip. This zip file will include all of the documents within the repository that you are viewing, along with the CSV file of the data. This process can be repeated with each of our 4 data sets using the code button to get the CSV and any pertinent documents needed to utilize and understand it, such as the code book and release notes. A word of caution, these data sets are all quite extensive and spanning a long time, so they may take time to download and fully load onto your computer. Before we conclude our webinar today, I would like to open up the Q&A chat that Tracy mentioned at the beginning for questions, either about the project for all of our panelists or about a specific track with the time that we have left over. For those who do not wish to join the Q&A portion, thank you so much for joining us and have a great rest of your day. I will now pass the floor to Jeff, our Assistant Track Manager of Vaccine, to field any questions.
Thank you, Evangelia. So as she mentioned, please keep fielding questions if you have any questions in the Q&A portion of the webinar. We have a few questions coming in already, so let's get started. Looks like the first question is for Aisha. for the health equity track. What are some similarities and differences between the states that are reported in race and ethnicity data?
That's a great question. Thank you for asking. There are more differences and similarities, but a common similarity is that this data is reporting in the state level. So they are in state websites. So with websites for states, and they're located in one place, but there are some counties that report this data per county level. So we have to go into each county and find the data there. But one of the biggest differences that we've also had is that every single state reports race ethnicity differently. For example, a common difference I've seen is some states report unknown separately from another state reports them both together. So we've highlighted in our GitHub where you find these differences between states.
Thank you, Aisha. For our second question, this is directed for Allison, the policy track. Are there any orders still being released regularly at the state and/or city level?
Thanks, Jeff, for passing that question along. So there are actually orders still being released on a very regular basis. Each week, we gather those orders from the state, city, and county level. And those orders can range from 15 orders a week that are brand new all the way up to 60 to 70. It really depends on what previous orders are expiring or in need of renewal, or if anything new has come about, like the vaccine boosters or anything else that comes out that needs official orders related to it. We are seeing those still every week.
Thank you, Allison. For our next question, this one is directed towards Sarwat. When have you guys started to report probable cases and deaths?
That's a really good question. Thank you for sharing that, Jeff. So not most states actually at the beginning of when we started the internship did not report probable cases and deaths. They rather just reported cases and deaths as like a cumulative number. And about July of 2020 is when the majority of our states began splitting up cases and deaths into confirmed cases and confirmed probable cases and confirmed deaths and probable deaths. And that's when we updated our data reporting to reflect that as well.
Thank you, Sarwat. Looks like our next question is for the vaccine track for Kaiynat. Is historical data available within the data?
Thanks for passing that question along, Jeff. Historical vaccination data is available for some states for all the variables that we are looking at. Some states only have historical data available for total doses, and then other states also just have that data available at the state level and not the county level. In most cases, data is updated daily and overwritten, especially for county level reporting, and this is captured within our release notes as well.
Thank you, Kaiynat. So it looks like there aren't any more questions coming in. If there aren't any more questions, I suppose I will now give the floor back to Tracy for a wrap up.
Great, thank you so much. Well, thank you everyone so much for joining us today. I hope you can see that a common theme is that a unified data set, or at least data sets with common definitions for variables, is a really, really important part of the national pandemic data set. I've been so honored to be part of a passionate team. Thank you to all of the leaders that presented today. And thank you, honestly, to all of the volunteers who've helped us throughout this past year. We're really excited that more and more investment has been done within the data field, and we look forward to seeing where it goes. If you're interested in reaching out or have any other additional questions, feel free to contact me. We will also be sharing the link to the GitHub, as well as a link to our recently published journal article outlining our different methods with comparing our data collection methods on COVID cases to other comparison data sets. And we'll be sharing that along with the webinar recording and a follow-up email. So once again, thank you so very, very much, and good luck with your research. Bye, everyone.